I'll be discussing motility testing in clinical practice. We will be covering today esophageal and anorectal manometry, antroduodenal manometry, colonic manometry, and transit studies. So let's start with a case. We had recently a child, a young boy of 4 years who had history of recurrent aspiration pneumonia, and on past history he was found to have a congenital tracheoesophageal fistula at birth, and he was operated for the same, and his manometry showed that he had lower esophageal sphincter pressures with ineffective motility, which probably explained his symptoms of recurrent aspiration. So we do commonly get to see these reports in our clinical practice, but first we need to understand the different tests and how do we interpret them. So we all know that esophageal manometry is a motility diagnostic system which measures intraluminal pressure from the pharynx to the stomach using closely placed pressure sensors. The common indications for which we get referred these cases are children with history of dysphagia, recurrent aspiration, recurrent food impaction, chest pain, refractory heartburn, or regurgitation. If the patient has reflux disease or a hiatal hernia, they may present with ineffective motility or primary esophageal motility disorders like achalasia, distal spasm, or jackhammer esophagus. Secondary esophageal motility disorders like this case in a patient who is operated after tracheoesophageal fistula. We need to evaluate esophageal motility prior to fundoplication and even in patients post-fundoplication to assess the level of dysphagia. Rarely we get a referral for diagnosing rumination, and of course we need a manometry to localize the LES prior to the pH probe placement. So how do we do the test? We use 16 to 32 channel water or solid catheters. In our center we use a water perfusion catheter. This is how typically a normal manometry looks like. The different colors are the different pressures which you can see here. That's the upper esophageal sphincter, that's the lower esophageal sphincter, and this wave-like contraction is that of the esophageal motility. In a patient with hiatus hernia, you may have a normal motility, but if you see a few centimeters below the lower esophageal sphincter, you will see high pressure areas, and when the patient inspires deeply, these become prominent, and this is the crura of the diaphragm. If a patient has ineffective motility, it should be present in at least 50% of the swallows, like in this case, or there may be weak esophageal motility. In patients with dysphagia and regurgitation, we now have the Chicago classification, which subclassifies achalasia into 3 types, where you have type 1, in which there is no lower esophageal sphincter relaxation. You can see that it does not relax, and there is no wave-like contraction. If you see absent lower esophageal sphincter relaxation, and you see this vertical pink bar that suggests that patient has a pan-esophageal contraction, this is called type 2 achalasia. And if there's a spastic element in the lower 2/3 of the esophagus with high amplitude, then you call this as a type 3 achalasia. In a person with non-cardiac chest pain, you may present with a high amplitude contraction or a high distal contractile integral. If more than 8,000, you say that the child is suffering from jackhammer esophagus. If the lower 2/3 of the esophagus contracts simultaneously, then we say that the time from the swallow to the CDP point is the distal latency, and if this is short, you say this child has got distal esophageal spasm. Rumination. For rumination, we need a manometry with impedance. So in the manometry, you can see this wave-like contraction, that's that of the esophageal body. But these lines that are running horizontally across are the impedance channels of the manometry catheter. And you can see that here the lower esophageal sphincter is relaxing, and this inverted R waves, you can see there's a drop in impedance. This is the part of the rumination. What are the indications of antroduodenal manometry? If you want to differentiate a true motility disorder from a somatoform disorder to help us to evaluate and treat pseudo-obstruction. It is used to evaluate children with severe nausea, retching, those who don't tolerate enteral feeding, to differentiate between rumination and vomiting, and to assess the gastric and small bowel response to various medications. So in a normal child, in a fasting state, when we do the anteroduodenal manometry, what one looks for is the migrating motor complex 3. And you can see that there are antral contractions and small bowel contractions. These are random contractions which are seen, and you need almost 2 hours of recording to pick them up. In the postprandial phase, you will see high amplitude repetitive contractions both in the antrum and the duodenum, which is in response to the meal. So this is a normal child. What's anal manometry? When we measure the pressures within the anal canal and rectum, the commonest indication we get is for constipation to rule out Hirschsprung's disease. We also get cases referred for diagnosing defecation problems after surgery for Hirschsprung's disease. If there's a child in whom you suspect obstructive defecation or dyssynergic defecation, then the manometry helps us. Patients who may be suspected to have internal anal sphincter achalasia or the effect of botulinum toxin, or in children with sacral agenesis. These patients will usually all present with constipation. In fecal incontinence, in patients with perianal trauma or overflow incontinence, may be referred for anal manometry. How do you do it? We place a single catheter with a balloon, the blue balloon which is placed in the rectum. The balloon can be inflated to measure rectal sensory and balloon defecation. That's how the normal anal pressures look like. So this bar which is running across horizontally is the different colors are the different pressures, and that's a normal anal resting pressure, and that's an elevated pressure. As you can see from the picture, this is these two are hypotensive pictures. So what does the resting pressures tell us? It tells us the status of the internal anal sphincter. When we want to know external anal sphincter, then we tell the child to squeeze or to hold tight. So that's a weak squeeze, and that's how a normal squeeze is. Children with defecation disorder sometimes cannot squeeze, cannot push out, and have poor rectal propulsive forces. In a patient with Hirschsprung's disease, we inflate the balloon in the rectum and look for anal sphincter relaxation. Like in this one, this is where the balloon is inflated. In Hirschsprung's disease, this rectoanal inhibitory reflex is classically absent. Pelvic floor dysfunction, when a child who is cooperative and who allows the anal balloon placement and doesn't need sedation, you can ask them to expel a balloon. And some children cannot expel a balloon because they are paradoxically contracting the anal sphincter, and these patients need biofeedback retraining. The common indications for colonic manometry are to differentiate functional constipation from colonic inertia, to help us diagnose patients of chronic intestinal pseudo-obstruction, to plan surgical interventions in patients who have refractory constipation, to decide if the diverted colon can be re-anastomosed in a child who has been operated, who's had a colonic resection or a partial resection with ileostomy, to assess improvement in dysmotility if an ACE procedure has been done for chronic constipation, and to evaluate persistent symptoms following surgery for Hirschsprung's disease. The catheter has to be placed in the cecum. That's usually how it would be placed. But of course, if you have chronic constipation with a dilated sigmoid colon, you'll see that the catheter will coil, and with a lot of difficulty, it has to be placed endoscopically into the cecum. A normal colonic manometry shows high amplitude pressure contractions right from the cecum coming up to the sigmoid. The normal gastrocolic response to a meal shows that there is contraction after a meal, but we have to watch whether there are any HAPCs or high amplitude propulsive contractions which come right up to the rectosigmoid. These lines which are progressive, they are the HAPCs, and in patients with constipation or with pseudo-obstruction, these may be altered and they may be short and come up only up to the transverse colon. So what do you see in a patient with constipation? First, let's see in a normal person. So that's the cecum, that's the rectum, and this is chyme. So in a colonic manometry, you have these high pressure contractions which start from the cecum and come up almost up to the rectum. They are present more through the day. You can see the density. They are absent at night time. They come again at waking, and that's why our parents always told us that's probably the best time to go to attempt to defecate. They come after a meal. So that's in a normal person. But in a patient with chronic constipation, this is altered, and you can see that the contractions first have lower amplitude. They don't come all the way down to the rectum. They are present all through the day and night. They are not increased during waking time, and the response post a meal, that is the gastrocolonic response, is blunted. In colonic transit study, we assess total and segmental transit times in patients who are suspected to have slow transit constipation. We have two methods of doing it. One is the traditional marker study. Of course, we need to have children who can swallow the capsules with the markers, and we look at where there is a holdup, whether the holdup is in the body of the colon or in the rectosigmoid, as in patients with obstructive defecation. We now have something known as a smart pill. So you just swallow this capsule. So of course the child should be able to swallow the capsule, and you can measure, it measures temperature, pH and pressures right from the stomach to the end of the colon. So it's a single test. It's very expensive, where you can measure gastric emptying time, small bowel emptying time, and colonic emptying time. So in summary, gastrointestinal motility testing is indicated if it will lead to a clinically important alteration in diagnosis, treatment, or prognosis. Thank you.